Welcome everyone to our session, The Value of Post-Professional Residency, Fellowship, and PhD Training. I hope you're enjoying CSM 2021 so far. My name is Carol Tucker. I'm from the College of Public Health at Temple University in Philadelphia, Pennsylvania, and I'll be joined by Michael Beatty and Jennifer Stephen Lapsley, both from the University of Colorado, out in Denver, Colorado. Technically Aurora, but Denver's close enough. For disclosures, we have no relevant financial relationships to disclose. Our learning objectives basically cover the advantages of post-professional education, key differences between them, how to optimize your choice of programs, how to optimize your application. What are some key questions we'd recommend you ask to look at both your mentor fit as well as the program fit? The outline of our content, I'm going to be doing the first part of the session. I feel passionately that we need more rigorously research-trained PTs. So I'm going to try to set the big picture framework on why research is important and research-trained PTs are important. Dr. Stephen Lapsley will then follow up with some PhD and research training pathways, pros and cons, some really insightful information. And then Dr. Beatty will finish up with some residency and fellowship pathways towards the end. This is a session that has 30 minutes of interactive discussion, and we look forward to answering your questions there, or as we're doing in CSM 2021, within a chat box. References, so you have them. And I'm going to start, now that you know what I look like, I'm actually going to close myself off. And so I look forward to seeing you during the interactive session. So I want to talk a little bit about physical therapy pathways, and as I mentioned, specifically why research matters. Three things. The take-home message that I will go back to at the end is, as we know, APTA wants to build a community that advances the profession about transforming movement, transforming society, optimizing movement, really improving health. To do that, we need a continuously updated evidence base. We need data, we need knowledge that specifically addresses aspects of our field to move us forward. We, as physical therapists, need to engage, inform, and do physical therapy research and rehabilitation research. I think we are so well suited to really ask insightful questions and to figure out the best way to answer it in a way that's meaningful to not only our profession, but to the patients we treat. And I want you all to think really, how will you move beyond entry-level knowledge, and where do you want to be kind of on this continuum of clinical practice, generating knowledge, research? Where do you fit? So when we look at the physical therapy evidence base, and this is a schematic that is part of the revised research agenda for physical therapy, the reference is at the bottom. And when we look at the evidence base for physical therapy, all of the little ovals in this circle that I've circled in red, or indicated in red, need strong research training. So epidemiology, basic science research, measurement, validation. So beyond entry-level practice, if we're going to build out our evidence base, we need physical therapists trained within these research-specific areas. I want to be clear on some definitions. Yes, a DPT is professional doctorate. It's an entry-level degree, just like MDs or doctor of nurse practitioners. Those individuals are trained, highly trained, to succeed providing clinical care. A doctoral degree, sometimes a research doctorate you may hear, or a terminal degree, is really those programs that prepare students to make original intellectual contributions, so to generate knowledge. It's not intended to teach people how to be licensed physical therapists. A postdoc researcher is someone that actually is conducting research. So that is their job full-time after the completion of typically a research doctoral studies. There's some other emerging models that maybe you could couple a postdoc with a DPT, and there are pros and cons to both of those, and we'll be glad to address those in the interactive session. So just to frame this, for DPT education, we have 11,000 DPT grads a year, coming out of 267 programs. 35%, about a third of those programs, are nestled in universities that are considered research universities. And if you're a DPT program in one of those research-intensive universities, there's usually more opportunities to understand the culture the nuances of research. And so we would love to see more DPT programs or a greater proportion of them in that position. But right now, over the last 10 years, what we're really seeing is more programs being brought forward at non-research universities. Again, nothing wrong with the quality of that entry-level education. It just adds a different kind of a flavor relative to the research intensity. There's about 40 programs that would be considered research doctorate programs, be it in movement science, biomechanics, neuroscience, rehab science, PhDs and PTs exist. And if we assume each of those graduate about 3 graduates a year, that's 120 grads per year in comparison to the 11,000 DPT grads. So drop down to about 1%. And then just as it is a big part of this session, there's 300 plus residency fellowship programs, and that number changes fairly rapidly. And again, a conservative estimate of 3 graduates a year gives us about 900 graduates of PT and residence fellowship programming. And so looking at the range of those programs, clearly we're producing fewer research doctorates than the other, which is not unexpected, but it's just something to keep in the back of your mind. When we look at DPT core faculty, 50% must have some form of a terminal degree, or here I call it a research doctorate. There's about 2,400 core faculty positions in the US, 7% of those are vacant. If 50% of core faculty have to have PhDs, if you're one of those doctorally trained people that are looking for an academic career, it does give you a little bit of an edge. When we look at current faculty, 59% have these terminal degrees or research doctorates, and that's been a pretty steady, no change, no increase or decrease. There are 47% of clinical faculty have clinical specialists. That's increased about 12% since 2010. For the core faculty roles, I want to point out that scholarship is important, whether you're a clinical or a research faculty producing scholarly work, and we'll define that in the next slide. Is an important part. It's generally about a quarter of people's jobs, core faculty. And 51%, again, that 50% kind of number, of core faculty are on a tenure or tenured or on a tenure track job. And if you're looking at program directors, I should say track, 68% of those are on the tenure track line, and there's a reason for that. But that means that their job, in addition to teaching and administration, is really to produce that knowledge and to succeed at scholarship and grant writing. So when we look at DPT Faculty Scholarship, and again, in this top slide, what you're seeing is our scholarship productivity. So if we assume that there's about 2,400 core faculty positions, and we know that 1,200 of them are in these research positions, these tenure track, we're producing peer-reviewed articles, and if you remember from evidence-based practice, those are kind of the gold standard. So per year, we produce as a global, not a global, but a national PT core faculty, about 3,000 peer-reviewed articles. In terms of grant funding, those 1,200 tenure track faculty are primarily the ones that do get extra mural research funding, and we have 837 core faculty that have some form of grant funding. NIH is kind of considered everybody wants their NIH grant, and we bring in about half of our research funding, a little more than half, is from NIH. So those are really impressive statistics in terms of really seeking out and being able to get NIH funding. As we move on, the take-home message really is that research in physical therapy, research-trained PTs do obtain NIH level funding. And again, there's other federal funding. It could be the Department of Defense or PCORI or NIDLR. There's foundation funding, which I don't want to undersell, but kind of what everybody aspires to, the NIH funding we do receive. About $457 million of the NIH budget. They have a budget of $42 million, but PT core faculty bring in about $457 million. And in 2018, as I looked through the NIH portfolio, about 149 of those were labeled rehabilitation projects. NIH believes in rehabilitation research. There is the National Center for Medical Rehabilitation Research. So they have a whole structured program that's existed for decades, really focused on fostering it. And if you look at the role of physical therapy within those projects and the programs sponsored by NCMR, we have a large footprint. So rehabilitation science is fundable. There are funding out there. We compete for it. But it is, go out, let's do it, let's get you trained. So opportunities exist to advance PT science, to have knowledge generators, but what we really need is a cadre of rigorously research-trained PTs who can generate PT evidence. And that bottom chart that you probably have figured out really are just those numbers of research projects across the different institutes at NIH. Because research is so important to our physical therapy practice, ACAPT, one of the organizations, the Academic Council of Academic Physical Therapy, and I've messed up that acronym, but we'll talk about that too if you want, has a research-intensive program in physical therapy group. And they did a survey in 2017, mainly because we had been feeling that we were having a harder time recruiting and bringing in PTs to complete a PhD. And in part, this might be because we moved to a DPT level training, might be because there's other pathways available that would move you beyond entry level practice, such as residency and fellowships. But the take-home message is that the program capacity exists. We can train PhDs. We have sufficient program slots for people to be moved into. Funding always remains a challenge with PhD programs, but they are there. We do face recruitment difficulties, whether it's PT new grads coming right into PhD, looking at dual degree DPT PhD programs, which I believe Dr. Stevens-Lapsley will address, or we can address in the interactive session. And we also really would love those PTs after they've gotten some clinical experience to come back. Sometimes the most insightful questions about what we need to do and generate within our research comes from those that have clinical practice. But the bottom line is all these programs feel that their PhD graduates could really succeed getting tenure, pulling in external funding at research-intensive universities after they have that. And we all encourage kind of that extra layer of doing some intensive postdoc training where you spend a year or two just doing research as your primary job. So kind of bringing this back as to why it's really important that many of you in this room really start to consider a PhD in your future is our evidence base is reliant on people that have this research training and that can do this type of rigorous research. When I and this is my schematic of looking at your possible post-professional pathways, in that middle and down at the lower end of the way I've drawn this is DPT entry level. And so as you move vertical up this diagram, the structure of the education and the time investment increase. So if you go down that middle path, DPT entry level, certainly clinical experience brings in knowledge to the profession. Your advanced clinical training, the weekend workshops, your continuing ed, these are all ways that you can build your knowledge capacity, obviously. I then divided four other areas or two pairs of knowledge. One I've labeled clinically focused and one I've labeled more research focused training. So within clinical focused, you can go and do your advanced clinical certifications. You could take week-long courses that pull out some specific area of practice that you want to improve in. Or again, moving into something with more structure and time investment, maybe a residency and fellowship, which again, typically are clinically focused. You could also move down the blue path, if you will, that's research focused. So you could there's a plethora of university certificate programs out there. So not necessarily in clinical skills, but in areas that might be more academic or research focused. You could do an MS program. So even though you have a DPT, which is that professional degree, You could go back and do your Master's of Science in Epidemiology and Public Health. I have my Master's in Electrical Engineering, so my entry-level degree is a physical therapy degree. Went and did a Master's in Electrical Engineering, and then I did a PhD in Exercise Science. So you don't have to move through this. This isn't meant to be a linear pathway. You could draw arrows from any of these, figures to any of the others. I also have my pediatric clinical specialist. So even though I may be down the blue path, I've interleaved it with getting my clinical specialist, getting a Master's in engineering, and moving on. So there's a lot of different pathways within these blocks, and what I really want to encourage everyone to do is to take a pathway. I do have circled up in the left-hand side of this the people that are best prepared to generate knowledge for our profession, to advance our profession, to all of those things that we learn in our evidence-based courses. The evidence generators really are going to be most successful if they've had that PhD or a PhD in postdoc training. And I encourage all of you not to feel like it's an all or a none, but that maybe I start looking at that and start thinking about how that intensity can fit in with my training program. So what's next for you? In 10 years, what will be the evidence base for our profession if we don't have this cadre of physical therapists or physical therapy researchers, whatever their background is? Who's going to be generating evidence that we can provide to our payers or to our patients about what we do is effective? Also, as importantly, who will be deciding what evidence our profession needs? If we don't have physical therapists helping direct our rehab research agenda or our physical therapy research agenda, we kind of lose sight and control over where that goes. Who will be prepared to generate our evidence? I'm looking at people virtually in this room. Is there something in between doing a DPT and a PhD that can produce people that can meaningfully generate knowledge, as I call it? And that may be the DPT postdoc direct pathway we've talked about. But more importantly, I want you to really take home thinking about what is your path. When will you start? There is no ideal time to start anything. And if you keep saying, I'll do it, there will be a time when it seems the right time. It could be a long while. So the 3 take-home things, again, I want to bring us back to is, as a profession, we need continuously updated evidence, data, and knowledge to move forward. It's not going to magically appear on its own. Chances are high that that physician is not going to be doing physical therapy generation per se. We need to engage, we being us as physical therapists, engage, inform, and do physical therapy research. And if it's not you, who is it? And so if you're willing to think that it's going to be someone else, keep in mind it could be you. I'm going to encourage everybody, whether it's a residency or fellowship pathway or a PhD pathway, or finding a mentor that can structure you through some clinical areas of growth, move beyond entry-level practice. Challenge yourself every day. Explore, commit, start one small step. You may find that you do a small step and that pathway doesn't feel right and you go down another one. But whatever you do, just start to do that. And with that, I'm going to end this session and turn it over to Dr. Stephen Lapsley to walk you down some of the research training pathways.
Hello, my name is Jennifer Stevens Lapsley, and I'm a professor in the physical therapy program and the director of the Rehabilitation Science PhD program at the University of Colorado. And I'm going to be talking to you about the value of PhD training. So the first question you have to ask yourself when you're considering residency versus fellowship compared to PhD training is, what are your goals? Are your goals to focus on management or clinical roles, or be a clinical expert and specialize, or develop case studies on individual patients, all of which are important? Or are your goals to be a professor in academia, to have an opportunity to change and advance clinical practice on a larger scale, or conduct large-scale funded clinical research on population and health systems levels? When I mention getting a PhD to individuals, there are a number of considerations and concerns that are voiced. One of those is financial. So many individuals, understandably, don't want to incur additional debt by going back to school and getting a PhD. So I'll touch on this in a little bit more detail in just a minute. But the other consideration is fatigue from being in school for so many years. And that's certainly an important consideration. One option is to take a break between DPT and PhD training, although it's hard sometimes to take a break and then come back, because once you've lived the life of a non-student, it's hard to come back to being a student. Another option is to find a program that has coursework that's manageable so that you don't feel like you're in the classroom all the time. For example, our program at the University of Colorado, students really only take courses for the first year and a half, and their coursework probably makes up about 50% of their total time in that first year and a half. And then most of their experience is practical and hands-on. Another consideration that students voice when they're considering a PhD is that they want to maintain their hand in clinical practice. And there are lots of opportunities to ask clinical questions in the course of your PhD training that allow you to interact with patients directly. For example, many of my students treat patients or interact with clinicians and mentor clinicians in the treatment of patients for numerous clinical studies that are related to their PhD training. And finally, work-life balance is an important consideration. And I'll have to say, in this area, what I find is that the academic work that I do is so rewarding and so varied and so engaging that a lot of times my work doesn't feel like work. And so while I may put in extra hours, I don't necessarily feel as drained as if I were doing the same types of activities day after day. So work-life balance is possible. So an important consideration is whether or not there's going to be a job for you at the end of your training. You should ask that with any next step, any career move that you take. And it turns out that there's a growing need, as Dr. Tucker mentioned, for additional PhD trained faculty across the country. And in fact, CAPD is requiring that 50% of faculty have a PhD or higher degree equivalent. And that's driving programs to very specifically look for faculty that have PhDs. So the job market is good. There's no doubt about that. What's interesting is when I compared a position with DPT, there was an academic position that for which DPTs were eligible to apply compared to a PhD research position at our institution, there was an 8-fold greater number of applicants for that DPT position. So it's much more competitive. Whereas the PhD position had much less competition during the same or comparable time frame. So getting a PhD also makes you more competitive within the job market down the road. So what does a professor do? Well, I won't touch on this in great detail, but what I love about being in academia is the variety of things that I'm able to do. So everything from research to teaching to service to clinical. And at any given time, I can mix and match these different respective areas to meet my interests and the needs of our department. So now let's get back to the financial piece, which is often one of the bigger barriers. And I'm going to show you some data where we've modeled out kind of the deficits associated or the opportunity costs lost with getting a PhD compared to earning potential down the road. And we're assuming 4 years for a PhD with roughly a $30,000 a year stipend. Paid tuition, which would be about $8,000 to $20,000 per year, although that's not added into the models. It's just so that you have an awareness and appreciation for some of the additional benefits of PhD training in many full-time programs, as well as paid health insurance. And the data that I'm going to share with you assumes no additional scholarships, so it's kind of the worst-case scenario. But there are a lot of scholarships that can supplement income if you're successful and you're competitive. There's the Foundation for Physical Therapy scholarships, which can allow for up to $45,000 in additional income during PhD training, as well as scholarships through the APTA sections, National Institutes of Health, or foundations. On average, getting a PhD allows you roughly $20,000 to $25,000 more per year in academic earning. And if you're engaged in research, in the red, you see an even greater differential. So clinical faculty in gray, or clinical people that, individuals who maintain a career clinically are represented in gray. DPT faculty are represented in blue, and you can see an increase in earning potential compared to clinical individuals. or solely clinical individuals. And then individuals who choose to get a PhD in yellow that are more teaching oriented. In other words, they have scholarship that's less than 50% time. And scholarship is usually that research component. Individuals who have scholarship or research that's greater than 50% have an even greater earning potential. And in fact, at the level of full professor, the average salary for a research full professor is comparable to the average salary from CAPTI data across the country for PT program directors, roughly sitting at about $147,000. And so you can see that the early investment in PhD training pays off over time. Another thing that I haven't factored into those calculations are loan repayment grants. So it turns out if you're invested in research, the federal government will pay off 100% of your federal student loans if you apply for a loan repayment grant and are successful at competing for one of these awards. We've had a high rate of success for individuals getting these awards, and they'll pay off all your loans, undergraduate and graduate. There's more information on their website accordingly. Here's the opportunity cost. So when you have a loan repayment grant, so if you look at the red, we're modeling individuals that had the majority, or that in the dotted line that got a loan repayment grant and are also research oriented, which usually go hand in hand, compared to individuals who didn't get a loan repayment grant in the solid red line. And the yellow line are individuals who got PhDs who may not have been research intensive focus in terms of their career tracks. And this shows you kind of where the payoff is. So for individuals with a loan repayment grant who are focused on research, within 8 years of completing their PhD, within 8 years of starting their PhD, they have broken even, and you can see a substantial increase in earning potential over time, proportional to individuals with just a DPT. Individuals who didn't get the loan repayment grant break even around 10 or 11 years after starting their PhD, and individuals who get a PhD without a research intensive emphasis still break even about 13 and a half years after starting their PhD. So that's pretty remarkable in terms of the cost, the opportunity cost over time. I also want to thank Sherry Ledoux for helping with the modeling associated with those graphs and the data that we worked with in order to generate that information, both CAPTI data and the Bureau of Labor data for 2019. So there are also additional faculty opportunities that you can see here: consulting, patents, royalty opportunities, paid travel, editorial board memberships, continuing education, teaching opportunities. So those are other doors that open with a PhD. But one of the things I always emphasize is certainly the finances should not be the reason to get a PhD. But my point with all the financial illustrations is to emphasize that maybe the finances shouldn't be a reason not to get a PhD. If you can make it work in the short run, it's going to pay off in the long run. But what are the additional doors that open with a PhD? Well, there's just such a tremendous feeling of satisfaction that comes with impacting and advancing our profession. There's intellectual stretching and challenge. There's tremendous flexibility. I love being able to schedule my days in ways that I can still attend my kids' events. And maybe I am working on a weekend or an evening, but I have the flexibility to work when I want to work. There's also a tremendous sense of professional connectedness, and travel and mentoring the next generation of PTs is one of the most rewarding aspects of my job. So what are the characteristics of successful PhD candidates? Well, I'm asked this question a lot, and one of the primary things that I look for is someone who has perseverance and tenacity. And I'd say also flexibility, but you need to be willing to, in the face of uncertainty, continue to march forward, or in the face of rejection, try again. That first grant may not get funded, the second grant may not get funded, but you need to be able to go after that third attempt and eventually secure funding. Cogency is another thing on the list. So the ability to clearly articulate ideas in person and in writing, and self-discipline, because unlike a DPT education, there's a lot of open-ended time that you have to structure, and you have to set your own goals and stick with your own timelines. If you're looking for a list of PhD programs, the APTA has a website where all the programs are listed, and you're welcome to peruse that and contact program directors as your interests in particular programs warrant. So what should you look for in a PhD program? Well, one of the most important things is that the research interests match your interests, but the reality is that a lot of times the match isn't perfect, and that's okay. The important thing is that the environment is the right environment for you. So you need a match, but the training is designed to develop skills on how to go about the processes of conducting research that you can then apply later to any patient population down the road. So identifying a good mentor that has an environment in which you can learn and grow is far more important than the specific line of research that they may be conducting or the specific population of patients they may be working with. Another consideration that I mentioned earlier is to avoid programs with excessive coursework. For example, I mentioned our program has very little coursework, but enough to lay a firm foundation for students to then focus more on practical applied skills. Our program has 30 hours of didactic coursework followed by 30 hours of thesis or dissertation credits. And then it's important to look for a program where students have a history of getting funded. The past predicts the future, so look for success. Look for a program within an institution that's large enough to support a variety of collaborations because your interests may change over time. I've certainly seen that happen over and over again. And then look for a program that gives you at least some teaching experience. It doesn't have to be a lot, but you do need something in order to be successful down the road as you enter an academic environment. So what to look for in a PhD program when you're considering full-time versus part-time? The reality is that a full-time program is going to allow you to finish sooner. It's often going to allow for paid tuition and health insurance. It's going to allow you more productivity in the short run in a shorter period of time. And then you're going to be more competitive for scholarships and things like loan repayment grants. So if you're really interested in research, a full-time program and the immersion in research will position you well for some of those more competitive opportunities down the road and allow you to start earning back the investment of that PhD training sooner. But a part-time program is a good choice for many individuals as well because you can work clinically while completing your PhD. And it does require many cases that you have to pay your own tuition, but maybe your health insurance benefits are still covered by your employer, and so you don't have to cover those. But one important factor is a lot of times part-time programs and students engaged in part-time PhD training don't qualify as readily for these loan repayment grants. So what should you look for in a PhD mentor? Well, the mentoring experience is a very important part of the process. So making sure you have a mentor that's really invested in creating a good learning experience is essential. The productivity of the mentor is important because that's going to generate productivity for you as a student or a trainee. Their grant funding is important because it's going to provide resources for you to do the work that you want to be engaged in. Track record of students getting funded. If they have a strong track record if that mentor has a strong track record with their students getting their own funding, that will bode well for you as a trainee as well. And then, of course, making sure the learning style matches how you work and learn best. Do you want a hands-on mentor or a hands-off mentor, depending on what your learning style is? And then finally, you want to make sure that there's a history of graduates getting desired jobs upon graduation. I told you the job market is very good, but just check and see that people are getting the jobs that they were hoping to be able to secure when they graduate. I often get asked, well, how do you prepare for PhD program training? And one of the most important factors is getting involved in some aspect of research to test the waters. See if it's for you. See if you're passionate about asking clinical research questions. Visit research labs. Talk with the mentors. Talk with the mentees. Make sure you get a good feel for the mentor's perspective and the environment overall. So hopefully I've touched on a variety of different factors that are often mentioned to me, at least, in terms of PhD training considerations. If you have additional questions, you are more than welcome to reach out to me. Mike Body is going to continue and talk more about residency and fellowship training opportunities, but feel free to contact me in any capacity if I can help you in your career path and your choices and your journeys of whether or not to pursue PhD training. Thank you very much for your time.
Hi, everyone. My name is Mike Body, and it's my pleasure today to be speaking to you today about the Residency Fellowship aspects of our post-professional education presentation here today. Just some pertinent background about myself. I'm currently an associate professor at the University of Colorado Anschutz Medical Campus. I myself underwent fellowship training in 2008 at Duke University Medical Campus in their Orthopedic Manual Physical Therapy Fellowship program. I was the first fellow to complete that program and helped to design that program. I was director of the Regis University Orthopedic Manual Physical Therapy Fellowship program. I've been involved in residency fellowship education pretty much since about 2008 when I completed my fellowship, as well as I completed my PhD in 2012. So that makes me a little bit unique, having gone through both experiences. So I'm happy to speak to both in our Q&A session that will be during CSM. As well as I currently teach in our Rehab Science PhD program and mentor both PhD and postdoctoral students as well too. So I feel like I have a good understanding of both post-professional education pathways and advantages and disadvantages. So I'm happy to dive in to the residency and fellowship aspects. So just some ground terminology. I find there's a lot of misunderstanding surrounding residency and fellowship educations. We'll just get on the same page first before we rapidly dive into why you might want to do one. So many of you are DPT students who are probably viewing this presentation here today, or just recent graduates. That's typically many of the individuals who come to our presentations when we're live at CSM. And so many of you might be completing your terminal clinical internships here currently. Just to clarify, so residency and fellowship are post-professional educational opportunities, right? And so that means you have to have graduated and already be a licensed DPT prior to pursuing any of these, and we'll talk about admission requirements here in a second. And so really residency is a specialization, and we'll talk about what specialization areas are available. But a common one that I'll give an example here today is orthopedics. But you then might choose to undergo a subspecialization, right? And that might be an orthopedic manual physical therapy like myself, but maybe you're interested in spine, a spine fellowship as well too. So there are other subspecializations, but that assumes you've already mastered kind of the general specialization area. So we have specialization and subspecialization. There's a lot of similarities between residency and fellowship structure. And so today I'll kind of gear most of my talk to residency side, because that's many of you will be entering in that pathway. But a lot of this extends naturally into fellowship opportunities as well too. Both have didactic and mentoring components, and both are obviously designed to advance your clinical reasoning and expertise within a focused area of practice. The differences between the two, as I just mentioned, the specialization versus subspecialization, they have their own DRP and DFP, which is description of residency practice and description of fellowship practice. And so that basically is outlining the content that residency or fellowship opportunity needs to cover over the course of your residency or fellowship, right? So they have different kind of didactic structures and what's supposed to be accomplished during that. And we'll talk a little bit more about them in the future. Mentor qualifications are different. And so I like to contrast this right away with your clinical experiences that you might have in your DPT program, where your CI, there's no like minimum set of standards that your CI has to have other than being a licensed physical therapist. But in residency and fellowship education, that's actually quite different. The majority of your hours do need to come from, in residency, a specialist in your area that you're studying. So they also must be, like, for instance, a OCS or an orthopedic clinical specialist to be providing that mentorship. Or when we go to fellowship, they need to be a subspecialist as well too. So the qualifications for your mentor go up as you go through your post-professional education track. And so that can be a tremendous advantage in terms of who you're working and receiving mentorship from. As well as residency typically culminates in being qualified to sit for your ABPTS specialist examination. And in fellowship, typically that does not culminate in anything, with the exception being the OMPT programs, which you are eligible to become a fellow of the American Academy of Orthopedic Manual Physical Therapists. But many of our other fellowships do not terminate in any additional credentialing or examination procedures. In terms of requirements, so residency, as I mentioned, once you're a graduate and you're a licensed PT in the state of clinical practice that your residency program is located in, you are eligible to apply for or eligible to start those residency programs. In fellowship, the difference is you need to have already completed a residency within that area, and or be a specialist in the specialization area. So you need to have your OCS prior to undergoing a subspecialization within orthopedics. That's a big change. So you might encounter individuals who were able to just get a certain number of clinical hours in a certain specialty area and then enter into fellowship, like myself. So I went directly into fellowship training. That is no longer the case as of January 1st, 2018. Those rules have changed. So you do need to either have already passed your specialist certification exam and or completed a residency in the appropriate area. So what areas exist, right? So currently, here, you can see here on the left-hand side of your screen, here are all our current specialist programs. We have 312, so this is at the end of 2019 data that we have currently. We have 312 programs in residency. And I put the number of graduates here as opposed to the number of programs, because I think that's easier to see kind of how many slots are available as opposed to programs, because some programs might take only one resident, some might take several to even hundreds of residents in terms of if you have the capacity in your program to do that. And so these are the number of graduates, so it gives you kind of an idea of how many spots are available in each of these different specialization areas. And then here are our fellowship programs. By far the most numerous are the orthopedic manual physical therapy programs, because those have actually been around longer than our residency programs. Like, for instance, the Kaiser Hayward manual therapy fellowship programs have been around since the late 70s, where residency education didn't really come on until the late 90s. So we have quite a few different residency and fellowship opportunities. So why might you want to do this, especially in comparing and contrasting to a PhD track? Dr. Stevens-Lapsley spoke to you about, really the main reason you want to pursue this is you want to become a clinical expert, right, in your area of practice, right? That makes a lot of sense. We're going to talk through but there's a lot of other reasons you might want to undergo residency and fellowship training, and they're pretty numerous. And we're going to go through each one of these in turn. So by far and away, mentorship to me stands out as one of the biggest benefits of residency fellowship education. Not only are your residency and fellowship mentors at a higher level of qualification, they're often very professionally involved. We'll talk about kind of criteria like characteristics that go along with residency and fellowship education in the future, but these are often very impressive individuals. And so I know that was, without my mentors, I don't think I'd be where I am today in the physical therapy profession. It's a very powerful experience, one-on-one, working with the toughest patients you might have. That's how my fellowship was structured, is that I'd have blocks of time during the week that I would actually put in patients that I was having trouble with, as well as my mentor would challenge me by putting patients onto my schedule that they thought would be good learning opportunities for me as well too. So you get a very powerful one-on-one mentored experience working with really your hardest patients in that specialty area, or subspecialty area. But mentorship extends beyond just the clinic walls, right? So it actually involves numerous levels within residency and fellowship education in terms of involving leadership, professionalism. They might be mentoring you or other people in research and teaching and education, your clinical reasoning, how to communicate interprofessionally, right? So there's a lot of different areas that you're going to be receiving mentorship in as a part of your residency and your fellowship program. There is a planned curricula as well too, so this can be very beneficial. There's a lot of people who say that I'm just going to study orthopedics and then challenge the orthopedic clinical specialty exam, which you can do if you have a certain requisite number of hours and you've studied independently. You can do that and challenge that examination. However, residency fellowship is a structured curriculum, which can be very beneficial to many individuals. And I know I appreciate structure and how to approach, especially some of these areas are really large, like how do I focus in my attention in key areas? And so they have a planned curricula. For residency education in particular, they have core competencies that actually span all residency programs, right? And so here they are on the left-hand side in terms of the core competencies that all residency programs address, as well as I put up an example of the description of residency practice in terms of the prescribed areas that you're going to be covering in terms of your patient care, And so this is also something that contrasts to your clinical education experiences in your DPT program, in that, the patients you see are just the patients that come in the door. When you enter into a residency program, and fellowship program, many have specific patient populations, either age ranges and or diagnostic categories that you need to see a certain percentage of during your time in that residency fellowship program. So oftentimes when you're in, like, let's say you're studying the foot and ankle unit, in your residency program, they'll be pairing you with a mentor who's an expert in that area to receive mentorship from, as well as oftentimes clinics triage patients onto your schedule that are in those diagnostic categories. So it's a very powerful learning experience. So you're going to make sure you get exposure. You're going to get the breadth of exposure in that specialty area that you need to complete your residency. So that's a very kind of sharp contrast from your typical clinical internship experiences. So this would be a pretty typical kind of schedule here shared by Boston University, their neuro PT program, their neuro PT resident. And this would be very similar to like an academic type program. We'll talk about programmatic models here in just a little bit. But you can see that they have about 75% of their week is dedicated to patient care, and that'll drive some of the salary and cost considerations that we'll see here in the future. But then they also have blocks of mentorship blocked out, like as I was mentioning earlier, as well as they have rounds where they're going to have their interprofessional education, as well as discussions of more complex patients. They might have education blocked out. As you can see here, they're doing some teaching and doing some in-services. They have research blocked out. Now, not all residency and fellowship programs require research participation beyond maybe just a case report, right? So that's something to kind of look at in your residency fellowship programs. What kind of research experience are you going to get within that program? Because it's quite diverse. As well as teaching is definitely not a requirement of residency fellowship education, but many programs do offer that. And so that's where you're thinking about what type of professional skills, in addition to becoming a clinical master, are you hoping to get out of your residency fellowship education. And you can see that also this individual has time blocked out where they're traveling to receive education as part of the residency. And in this example, they're flying to LA, where they're going to undergo some education for that the neuro section put together, the Academy of Neurologic Physical Therapy put together. And so that they'd be receiving their education during those time periods. All right, so I guess that covers, really kind of like what does the curricula / mentoring look like for these programs. A big question is, does residency fellowship education really make you a better clinician? There's actually not a lot of data on this, but there are starting to be more that's emerging. There's a study by Rodriguero and colleagues in 2015. That was in JSPT, and I'll have these in my references at the end of the presentation in case you want to go read more about these articles that showed that fellowship training led to better outcomes versus residency or non-residency trained individuals. And Winslow just recently published this last year in 2019, looking at the effects of implementing a hospital-based outpatient orthopedic residency program and how that affected their patient-specific functional scale outcomes over time. And you can see pretty dramatic change in their PSFS scores over time in terms of, which I think pretty indicative of their outcomes improving over time. And that this is about the best evidence that we have that shows that, hey, as you undergo residency fellowship training, we do see improved patient outcomes. But until we have standardized reporting metrics across all clinics that we all use, it's very hard to really track how these changes from post-professional education really influence patient outcomes. But we're starting to see more. Something you can easily do, though, is talk to graduates of programs, right? In terms of, hey, what do you feel you got out of this program? And Smith did that in 1999, and very, conclusively showed that, hey, a huge number of people said that, hey, residency education had a dramatic impact on my ability to really be a clinician, right? My clinical reasoning process, how I even do my exam, how I treat complex patients, a huge impact on how I'm able to do that. Interestingly, there's also a big impact on career interest and fulfillment. And one, I think if you're better at your job, you get more fulfillment out of that. But then I think also in knowing a lot of these residency directors, fellowship directors, and working with them over years, like these are inspiring people as well too. So I do think it does. When you enter into residency and fellowship education, you do work with individuals who are super passionate about a profession, super passionate about education and making physical therapy better. And I think that rubs off on you and really kind of sets you off. I know it did for me on a different trajectory in terms of your career path. And it really makes you think about what you can do in physical therapy. And, really they help to encourage you to really pursue your dreams as well too, and become the best physical therapist you can be. So I do think that really has a strong influence on your career and fulfillment as well too. And that's what Smith and colleagues found in their research. We do know that as well, it does open doors for you professionally. I would say not as many as a PhD, having gone through both processes and also being on the interviewing side for major academic programs in terms of how different degrees are really evaluated. I know Dr. Stevens Lapsley spoke to that a little bit, but we do know that in going through residency fellowship training, it can open up some career doors for you, especially if you're doing your residency at a major academic center that has a DPT program. Oftentimes you're getting teaching opportunities as a part of that residency fellowship education. And then they know you as an entity, and oftentimes that might lead into a job as a clinical instructor within a DPT program. I know, for instance, at the University of Colorado, all our clinical instructors have specialist certification. That's kind of a minimum bar that we have for our clinical instructors to come into the labs and work with our DPT students. So oftentimes that gets you over that threshold, as well as you often have a chance to meet individuals who are educating in that space as part of these programs as well too. So that does open up doors for you. So quite a few people who underwent residency training, they often would go on to fellowship programs. That's kind of a given now because you have to go through residency training. In the past, in 2008, when this was done, you could actually just go straight into fellowship training, right? Many would go on to board certification. Many would go on to serve as CIs as well too, participate as instructors, coordinate a course. It's much less in that category, but still some made it to that level, as well as serving as a faculty member within residency or fellowship education as well too. So those are some potential career doors that going through residency fellowship education could open for you. We do know that going through a structured curricula leads to better pass outcomes on specialty examinations. You can see this is the 2019 exam pass rates in every category for our specialty exams. People who've gone through a residency outperform those individuals who just challenge the exam directly through the direct patient care hours pathway and who study for that independently. The only exception being the cardiovascular and pulmonary exam from just this year, because there's only 6 total residents that took that, and the individuals who went through option A outperformed them slightly by 5%. But otherwise, overall, you can see in some areas there's quite a bit more advantage, and this is an expensive exam as well too. So I think overall is about 13% increase in your chance of passing the specialty exam on your first time. A big question I get from a lot of people is, will I get paid more? Hey, this has some cost. We'll talk about the cost associated with it here in the near future. But there's some evidence to suggest actually you do get paid more. Recently, Whitman and colleagues put out some data just this year that showed that the average pay increase after completing fellowship training was close to about $10,000. And that's a good chunk of change, right? And Jones studied residency education in 2008, a little bit smaller study, and similarly saw a change in pay associated with that. I know for me, a lot of the residency fellowship requirements help for me to also, within my own hospital unit, to build along my leadership pathway. And so a lot of the educational activities helped me to climb the ladder and go from PT1 to PT2 or senior physical therapist, or however your promotion structure is set up. A lot of times these opportunities can help tick multiple boxes. So depending upon where you're working and how your career ladder is structured, residency fellowship education can really help to advance you within your unit as well too. And then I would like to say that, no matter what, you'll get experience in this specialty area. And sometimes that can be huge. Like some areas like pediatrics and sports, they're really hard to get jobs, especially as a new grad. in those areas. They're very competitive, and this will give you, a year or more of experience in that area. And so that can really improve your marketability, just having experience. I know many of our local clinics here in Denver, people love to move to Denver, right? And, they often demand 1 or 2 years of experience in orthopedics before you can go work in an outpatient orthopedic clinic. And so how do you get that experience when you're a new grad? That can be challenging. So residency fellowship education can be one pathway to ensure that you get the experience that you need to work in the area that you're most passionate in. There's some other considerations clearly in terms of, hey, residency fellowship education. There's different post-professional education pathways that we've already been talking about. And, really when people, my advisees come to me and they ask me, I am thinking about doing residency. Do you think I should do it? Well, the first thing I say, is this really the right time in your life to do this? Is this, good with your family, your living situation? Are you ready to dive right into residency fellowship education right after your DPT degree, right? So, where are you in your life is the first and foremost consideration. Then there's several others that we'll go through here in turn. So costs, that's a big one. You just spent, maybe hundreds of thousands of dollars. Hopefully not, but that's the reality is that a lot of us are going further into debt for DPT education. And residency is another cost, right? And so as I showed in that Boston University calendar of kind of the average week, you see kind of, hey, 75% of the week's dedicated to patient care. Those are their billable hours, and that's how the clinic they're working in is making money off that. And so typically, and I think this is kind of fair, if you're only seeing 75% of a patient load, they're going to pay you 75% of a salary, right? And that's how they make the economics of residency fellowship education work out. None of these programs are incredibly profitable. They're oftentimes break even or slightly net loss, but many organizations believe in this as a mission because they know it brings a lot of value back to in terms of their patient care, but as well as in their professional satisfaction that they're more than willing to invest in for their employees. But so typically you'd earn 75% of salary or you'll also see a tuition model. So there's two different types, right? And so you might also see a tuition model where you earn a typical salary, but then you pay for some of the didactic portion and the mentoring associated with that. ABPT RFE, which is kind of your main residency fellowship entity that I'll give you some references, a resource slide at the end in terms of where you go for some of this information. The mean tuition was about $7,200 for those programs that do charge it, but that can range up to over $26,000. So it's something to be aware of when you're looking at programs in terms of costs associated with it. You can also, there might be some loan deferment options depending upon the program. So that's where you need to specifically look at the program and if you would be eligible to defer loans, as well as if that's the right move for you in the grand scheme of paying off your student loan debt, because you might choose to, for instance, keep paying your loan so you can qualify for a public service loan forgiveness program, and or you might be in some income-based repayment vehicle where your loans are quite affordable and you're able to keep paying them down. So obviously you have to think about this in the context of your debt paid on strategy. There's some other perks, like you get some discounts on APTA dues and conference attendance as well too. Some key things to kind of think about that's not always advertised in a lot of the programs is that, they might structure your benefit package differently than if you're a full-time PT in their clinic system. And this is again due to just trying to figure out a way to get the costs of the program, the mentorship and the didactics you receive. Professional dues, some will require to be members of the APTA, some won't, some will pay those dues, some won't. So just to be aware of that. Some might have additional Con Ed requirements. We saw that resident was traveling to LA to do the Neuro Consortium residency education module. And so are those costs covered? Is the tuition for that covered? And as well as other travel costs that might be associated with the program, especially if you're like in a sports residency and you have to travel with the team, how are those costs covered? So just to be aware of. Program model. So this is something to kind of really think through when you're thinking about really your learning style as well as what your professional goals are to get out of the program. Probably the two easiest to contrast are your academic ones. So that'd be like the University of Colorado Anstis Medical Campus. We have a pediatric residency. And so that would be a a classic example of that, whereas we might have also a hybrid online program as well too. And there's several of those currently available, like EIM, Evidence in Motion would be a major provider of those education. So in terms of academics, these are typically considered to be the gold standard by many experts. Your instructors are typically national leaders in those areas, so your curriculum is very well built and maintained. You often have teaching and research opportunities associated with those that typically you don't have in many other programs. And loan repayment is much easier because these are academic institutions. The tough part is that they're very, very competitive. Oftentimes, so for our PEDS residency, we had 34 applicants, I believe, this year for one slot. Right? So that's quite competitive, and we'll talk about that here in the near future. As well as you'd have to move here to Colorado, right, to be in our PEDS residency program, and that might not be in the cards for you and your family. Right. For hybrid online, well, oftentimes there's no need to relocate. They have very well-developed curricula because that's really their strength, is that they leverage the number of residents they have to really invest heavily in their curriculum, which means that it might be a larger cohort, which can be an advantage to many of you. You might build better professional networks. You might learn better that way, or maybe not, right? So that's where learning style comes in, as well as oftentimes these are tuition-based models, and so your employer might be willing to pay that. I know I had many fellows in my fellowship program that their employer was picking up the tab for their fellowship education as part of their content costs because they wanted to keep them, and they saw this as a way to invest in their clinicians and get them stronger, as well as retain them. And so oftentimes you might be able to get those costs deferred through your employer. So just to be aware of, a lot of these programs, they do have extensive mentor networks based upon their graduates and size here currently, but depending upon your geographic region, I know I had several fellows that really lived in an oasis of there is no one around that they could receive mentorship from, so they would have to travel to receive mentorship, right? And so they would fly in to work with one of our fellow graduates for a week, and they take off a week from their work, and they fly and they do 40 hours of patient care and mentoring with a mentor in our program, and that's just the only way they could get their mentored hours in. And I think that experience, it can still be a great experience. So I don't want to undermine that at all, because I definitely know a lot of people who have gone through pathways like that felt that it was a tremendously valuable experience. I have a personal bias that I like kind of the structured program where your mentor is in-house in the clinic, that you're working in, and that mentorship occurs very gradually over the entire course rather than bursts. But that's a learning style preference, as well as a reality of the constraints where you just have to deal with. I think in both situations, you can get great learning outcomes, because a lot of that really falls on the shoulders of the individuals, but it's just something to be aware of when choosing programs. Somewhere in the middle is the clinic hospital models. We have many hospital systems that have residency fellowship training. We also have many just single site clinics that decided to start up a residency program because they have those resources. So this is a very diverse category, so it's kind of hard to compare and contrast here. They can have a lot of resources, research opportunities, teaching opportunities, or none of those, right? So it's very diverse. The curriculum oftentimes in these is where kind of things may be a little bit in question. Many would maybe outsource to an entity like MedBridge, and that's where you have to ask yourself if one of the main reasons you like a structured curriculum, well, could I just pay $200 for my MedBridge membership for the year and study their orthopedic residency course that they have and do that as part of my professional education plan, or do I want to pay to do a residency where a bulk of the education I'm receiving is something I could receive for quite cheap somewhere else? And so that's something to be aware of in terms of where does their curriculum come from. And we'll talk a little bit more about those considerations. All right, so let's talk about them right now, right? So in terms of the curriculum, some things to just be thinking about. Hey, is it outsourced? Do you just use MedBridge or some other entity, or is it in-house? If it's in-house, how did you build it, and how often is it revamped? If you're in orthopedics, every year I have to update content on orthopedics because it's rapidly changing. And as I'd say, every year if PT practice is rapidly changing, they often say within 5 years, much of what you learned is going to be outdated. And I'd say that's very true from what I learned in physical therapy school, right? And so how often are they maintaining? How do they maintain that? What's the overall learning format? A lot of it's going to be online. Do I like online learning? Many of us have been forced into that for COVID-19, and so we're getting a good taste of what that feels like. Not all of us love it. Or is it mostly journal articles or presentations, or how is it actually structured? What additional resources are available in the program, and other educational opportunities, either mandatory or optional. So just things to consider in these programs, as well as mentors. Like, who is going to be your mentor, right? This is a big part of the program. Who is that individual, right? And so what are their qualifications, their years of mentoring experience, how stable is their mentorship pool? If there's only one person at clinic and they leave, what position is that going to put you in? As well as, is there any type of matching process that goes on, or how many will you have? The average is 2 to 3 mentors within a program, but some have many, some will have few. Okay. And is there some sort of evaluation of that mentoring process in the beginning, midterm, and endpoint to help inform that process? Location is a big one in terms of many of us have location constraints. And I can tell you, you can see that there's areas of the country where there is many programs, and then there's areas of countries where there's few. So for instance, the South Atlantic has the highest number of residency fellowship programs, but they might not have the exact residency and fellowship program you're looking for. For instance, if you're looking for a cardiopulmonary residency program, well, there's only a handful of those in the country, right? And so those are very specific places in terms of where they want to be. That's one of the reasons I had to start a fellowship program at Duke University, because there wasn't one that existed anywhere nearby that I could even think about relocating to. So I was very fortunate to have this set of circumstances and support to start a fellowship program where I already worked. But not everyone that's going to be available to. Thankfully, now that there are hybrid online programs for ortho, sports, neuro, and orthopedic manual physical therapy. And so if those are the residency fellowship areas you're interested in, that is also an option that wouldn't require you to relocate. There's some other considerations like application cycle. Everyone starts their residency program at a different time. And so depending upon your graduation, you might have this like odd gap of when you're supposed to start your residency and when you graduated. And so that might influence your choice of program, maybe, maybe not. Size of the program, I think this really comes down to learning style. Reputation and outcomes of the program. This is where I always like to talk to graduates of the program. Local respected physical therapies in the areas of these residencies. So typically like talking to your orthopedic instructors or your neuro instructors or your peds instructors on the reputations of certain programs. Patient population, this could be pretty particular in terms of like sports residency education. So in terms of if you're really passionate working with collegiate athletes, but you're choosing to do a sports residency that doesn't maybe work with collegiate level and or the sport you're interested in, that can be a problem in terms of the match between you and that residency. Time and travel requirements, especially sports, that can be quite high, as well as I would also say just in general, are you ready to work a little bit more? Typically, they say you're going to be at least 50 plus hours a week in terms of your residency fellowship education, because you'll have your clinical load, and then you have your education load, and there's really study expected outside of that. Are you really at that time in your life where you can take on that kind of added demand to complete residency fellowship education? And then a minor point is what stage of accreditation they are. Depending upon, they might be just getting accredited, and there's a risk that they actually might not go through. If you're in the candidacy phase and you're the first person to go through, like I was, if they don't get accredited, then you don't technically graduate from that residency because it doesn't exist, right? And so it'd be very unfortunate. It has happened in the past, so that's why I do mention it. But typically it doesn't, so this is a very minor point. As well as reaccreditation, it's possible for a program, if they come up, there's 5 and 10 year reaccreditation cycles. If they don't get reaccredited and you're in the program, then technically you don't graduate from it as well too. I don't think that it's a pretty rare experience, but it's just something to be aware of in terms of the overall considerations and what program you choose. Competition, this is the last big point here, right? So in terms of, hey, in some areas, there's very few programs, right? And so this is a good slide. This is from the 2017 annual report from ABTRI. And this might be the easier graph to interpret. It's where they plot out the additional capacity or overcapacity that we have with certain programs. And you can see that in terms of people who are interested in pursuing residency fellowship education, sorry, I guess besides just residency education, that we have a surplus capacity of orthopedic spots. So if you're interested in ortho residency, your odds of getting into any orthopedic program are better. But in pediatrics and sports, we actually have a deficit of programs in particular, where we definitely know there's more people who are interested in getting into those spots, but they were not able to get into the program. Right. And so peds and sports are our most competitive areas for residency education. But I would say even in orthopedics, where it says, oh, we have a lot of orthopedic programs, if you wanted to get into the Duke University residency program for orthopedics, they take 2 candidates every year and they get quite a few applicants. And I know some years they only select people that they've already been pre-identified because they work at Duke and they're already slotted. And so I know some years they've taken no applicants because they already have people identified in terms of those spots. So some of these residency programs can be quite competitive, especially the academic based ones. So how do I increase my competitive edge, right? So I think first and foremost, do your homework. I talk to past graduates of the program, learn about the program, think about its match for you. Do not call up and ask to talk to the residency fellowship director and ask them basic information that's easily available on the website, because it's a competitive advantage. And so if I know who you are and you're already contacting me and asking very basic information, I've heard this story before, and I know I've talked to other residency fellowship directors, like, yeah, that's not the type of candidate we're typically looking for. We're looking for someone who's a self-directed learner, motivated. And so I'm impressed when people call and ask me specific questions about our program. You can tell they've done the research and they tell they thought about the fit of our program with their goals and their learning style. And then I'm impressed with that candidate. So do your homework first and be prepared prior to having any conversations with people in the program. Make sure you have solid recommendations from people who are in that specialty, subspecialty area. That I think kind of goes without saying, as well as excel in your education in those areas. There are opportunities to meet the director of the program and get that face-to-face time. I know that ortho and sports have CSM events typically, as well as there are becoming more virtual fairs. I know pediatrics has recently had a virtual fair, and we look to see kind of more of those events in the future. But those are opportunities that do pop up in terms of being able to get a little bit more information on these programs and some face-to-face time with current residents, fellows, directors. That can be quite good. Show that you're ready for the program, master the basics, being ready to receive feedback. And then my favorite kind of competitive advantage is working for the organization. So that backdoor, I know many past students of mine, if they didn't get into their residency program of choice, were like, well, hey, how about I move to that area still, get established there as a clinician and try and get a job with that organization and then reapply the next cycle. Many residency fellowship directors really like hiring known entities. And so if you're already working for the organization, they know your capacity and they know that you're driven and you're more likely to stay there after graduation as well too. And that's something that they're very interested in, not only training future clinicians, but retaining really good clinicians as well too. So that's a favorite way if you don't get into your program of choice. Application process, so just some nuts and bolts. Many use our PTCAS, residency fellowship PTCAS. I know some of you are probably twitching hearing PTCAS right now, but there's the residency fellowship version, but not everyone's required to use it because it's a newer system. And there's some, if you were established prior to it being implemented, you had the option to opt in or opt out. And so some don't even use that vehicle for their applications. So you might see them listed in the program of directories, but then you go into RFPTCAS and they're not listed. It's probably because they have their own application process. So just be aware of that. Timing's all over the place. Yeah, I think the other thing I'd like to highlight from this, I think, is probably just to highlight that also some use an interview process, some don't. Some require that to be virtual, some are in person. I have seen programs that do in-person interviews that do skills examinations. They have you examine patients. They really put you through a thorough examination before inviting into their program. And so just to be aware of, if there is an interview, what is involved in that. So you're very prepared for that application process. Here are just a couple of key resources for you if you're considering residency and fellowship education. So ABPT RFE, that's a main site for you to go to learn about. They have a great kind of filter that helps you to kind of choose programs by region and type. That's quite helpful. And there's that link to RFPTCAS. All right, if you're unable to view this virtual presentation and or you'd like to see a version of this in the future after CSM, we do have a prior version at rehabsciencephd.com for our Rehab Science PhD program that involves this aspect as well too, as well as both Dr. Stevens Lapsley and I have done a couple of podcasts with Karen Litzy on healthy, wealthy, and smart. So you can go view those if you'd like a little bit more information about residency, fellowship, or PhD training. Here's some references of some of the studies I talked about today, should you wish to read those in person. And then we also added a handout slide that's kind of just a summary of our talk today in terms of kind of key differences between career paths, not our top 10, our top 11, because we always like to go above and beyond in terms of comparing and contrasting on what we think are kind of key characteristics in those individuals weighing. And then finally, I'd just like to say I hope to get to see you virtually. At CSM, we'll have a Q&A session. We're in the Academy of Physical Therapy Research, and that'll be on Wednesday, the 17th of February, 7 to 7:30 p.m. EST. So hope to see you virtually and look forward to hearing your questions then.